Good morning, everyone. It is 9 o'clock, and I wanted to welcome you to what I believe is the first ever virtual Advisory Committee on Immunization Practices meeting. Next slide. So I wanted to give you a little bit of background about how this meeting will be working today. The ACIP members, ex officios, and liaison members are on a Zoom call, as well as any invited speakers to this ACIP meeting today. The public will be watching this meeting via live webcast, and the instructions are online on the ACIP website. If you have any issues or concerns throughout the day, please email the ACIP Secretariat at acip@cdc.gov. Next slide. There are virtual meeting materials available today as well. If you go to the ACIP website and look under meeting materials for June 2020, you will see links to the slide presentations for today. These are not 508 compliant, and at the end of the meeting today, these slides will be taken off the website and will be finalized and made 508 compliant and put back up in the near future. Slides presented at this meeting will be posted at the ACIP website, typically 4 weeks after the meeting. The live webcast will also be posted on the ACIP website approximately 4 weeks after the meeting. Meeting minutes are posted on the ACIP website generally within 120 days of the meeting. Minutes from the February 2020 meeting will be posted on the ACIP website shortly. For all of you who are on the Zoom call, please mute your lines at all times until you're called on for discussion. Dr. Romero, our chair, will open the meeting for discussion, and please virtually raise your hand. During the discussion period, the ACIP chair will take questions in the following order. The first group of questions will come from voting ACIP members. The second group of questions will come from ex officio members and liaison representatives. And then third, anyone who is available to speak from the audience. We will stay on schedule per the meeting agenda, so even if we're running early, we will begin the next session at the time that is written on the meeting agenda. We ask that all people who are on the Zoom call to please disable your video. You can put a profile picture online, but we want to make sure that the Zoom call remains stable throughout the meeting. Next slide. So we currently have 2 additional ACIP virtual meeting dates added. The first date is August 12th, 2020, and the second date is September 16th, 2020. These dates are subject to change, and if there are any changes to these dates, we will update the ACIP website and send an email out to all subscribers to the ACIP CDC page. So if you would like to receive those emails, you can subscribe to the page on the website. Our next regularly scheduled ACIP meeting is October 28th to 29th, 2020. We do not know at this time if that meeting will be virtual or in person. We anticipate it will be virtual. Next slide. The Advisory Committee on Immunization Practices is at heart a public body. Engagement with the public and transparency in our processes is vital to ACIP's work. As you all know, this virtual environment makes this especially challenging, and I just wanted to make note that while we will have an opportunity for public comment today, we do miss seeing everyone here in person and being able to interact and connect in that way. As part of ACIP's continuous improvement, we've strengthened our oral and written public comment process. So we will have an opportunity for people to make oral public comment during the morning meeting today. It will occur prior to lunch, after the 2 sessions, and prior to any votes that will be taken. Additionally, You can submit written public comments, and the instructions on how to do that are on the ACIP website. You can submit written public comments for up to 24 hours after the meeting, and we encourage all of you to do so. Next slide. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, we've issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to these vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussion with the provision that he or she abstains from all votes related to the vaccines of that company. At the beginning of each meeting during roll call today and prior to each vote, the ACIP members will state any conflicts of interest. Finally, I want to remind everyone that while we are in a virtual mode, we are still taking applications for ACIP membership. This is to start on ACIP in July 2021. We are absolutely looking for potential candidates to serve as ACIP members. We would appreciate those of you to apply who are applying. Right now, the deadline is July 1st, 2020. We are going to extend that deadline to July 15th, 2020. And if you have any issues or trouble applying online, please reach out at acip@cdc.gov. Next slide. So I'm going to hand the meeting over to our venerable chair, Jose Romero, to open the meeting and to take roll call. I just want to ask everyone before we get started for their patience with the meeting today. We will do the best we can to make sure that the discussion goes as smoothly as possible, but there may be glitches, and we will try to address those as rapidly as we can during the meeting. The one glitch I know we will not have today is a glitch with electronic voting, so we can all be relieved about that one. But we know that this is going to be challenging, and we appreciate all of you at your computers watching this meeting and participating. Here we go. So Dr. Romero, would you like to take it over for roll?
Yes, thank you. So welcome all to the virtual meeting of the ACIP. And we're going to go ahead and start with roll call. I will call the roll. And then after I call your name, please state whether you're present, obviously, your affiliation, and whether you have any conflicts of interest. So I'll begin. Jose Romero, present. I'm the Chief Medical Officer of the Arkansas Department of Health, and I have no conflicts. Dr. Atmar, please.
Present, Professor of Medicine, Baylor College of Medicine, no conflicts. Thank you.
Dr. Alt, please.
Kevin Alt, present. I'm a physician at the University of Kansas, and I have no conflicts.
Dr. Bata.
I am present. Good morning. I have no conflicts of interest. I work at the Minnesota Department of Health.
Dr. Bell, please.
I'm present. I'm a clinical professor in the School of Public Health at the University of Washington, and I have no conflicts.
Dr. Bernstein.
Henry Bernstein. I am present. I'm a professor of pediatrics at Zucker School of Medicine at Hofstra Northwell. I have no conflicts.
Dr. Fry.
Sharon Fry, present, no conflicts. I'm a professor of internal medicine at St. Louis University.
Dr. Hunter.
Paul Hunter, no conflicts, family medicine, University of Wisconsin.
Dr. Lee.
Grace Lee, Associate Chief Medical Officer at Lucile Packard Children's Hospital, a professor of pediatrics at Stanford University School of Medicine, no conflicts.
Ms. McNally.
Good morning, Veronica McNally, President, the Franny Strong Foundation, no conflicts.
Dr. Paling?
Jose, Kathy was having trouble with audio and joined by phone. We'll work with her to get her on.
Thank you very much. Dr. Sanchez?
Pablo Sanchez. I'm no conflicts, and I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's and the Ohio State University in Columbus, Ohio.
Dr. Szilagyi?
Peter Szilagyi, present, no conflicts. I'm Executive Vice Chair and Professor of Pediatrics at UCLA.
Dr. Talbot?
Hi, I'm Kip Talbot. I have no conflicts, and I am an adult infectious disease doctor and associate professor at Vanderbilt University.
So let me welcome all of the voting members, and thank you for being here. Let me go on to the ex officio members, please. So I will call the center and then ask whoever is representing the center to please state their presence. So Centers for Medicaid and Medicare and Medicaid Services.
Mary Beth Hans is on.
Thank you. Department of Defense.
Eric Dusing, present.
Thank you. Department of Veterans Affairs.
It looks like a couple of members have said they might be late, so we don't have a representative at this time.
Thank you very much. Food and Drug Administration.
Dorian Fink will be joining in a few minutes.
Thank you again. Health Resources and Services Administration.
Mary Rubin, present.
Thank you. Indian Health Services.
Thomas Weiser, present.
Thank you. Office of Infectious Diseases and HIV/AIDS Policy.
David Kim, present.
Thank you. National Institutes of Health.
John Bagel, I think, is also joining later today.
Very good. So thank you all for being here. I will turn it now over to Dr. Cohen. Amanda?
Would you like for me to go through the liaison members to introduce themselves?
Oh, I'm
as well?
sorry. Forgive me, that's my mistake. Let's begin with the liaison representatives. I will call the liaisons by organization. American Academy of Family Physicians.
Pamela Rockwell, present, no conflicts.
American Academy of Pediatrics.
Bonnie Maldonado, Professor of Pediatrics, Epidemiology, and Population Health, Stanford University, member DSMB, Pfizer.
American Academy of Pediatrics, Red Book.
David Kimberlin, Professor of Pediatrics at the University of Alabama at Birmingham and liaison representing the AAP Red Book, no conflicts.
American Academy of Physician Assistants.
Good morning, Marie-Michelle Leger, Director of Clinical Education at AAPA, no conflict.
American College of Health Association.
Amy Chai, Physician at UNC Chapel Hill, no conflict.
And Sharon McMullen, Cornell University, no conflicts.
American College of Midwives.
Earl Hayes, present, no conflicts.
American College of Obstetricians and Gynecologists.
Linda Eckert, Professor of Obstetrics and Gynecology and Global Health at University of Washington, no conflicts.
American College of Physicians.
Jason Goldman, General Internal Medicine, present, no conflicts.
I'm informed that you do not have to disclose conflicts, so just present would be sufficient. Thank you all very much. American Geriatric Society.
Ken Schmader, present.
American Health Insurance Plans.
They will not be here today.
Thank you very much. American Immunization Registry Association.
Rebecca Coyle is present.
American Medical Association.
Sandra Freihofer, General Internist in Atlanta, present.
American Nurses Association.
Chad Riddle, present.
American Osteopathic Association.
Dan Grug, present.
American Pharmacists Association,
Steve Foster, present.
Association of Immunization Managers,
Christine Finley, present.
Association for Prevention, Teaching and Research,
Paul McKinney, present.
Association of State and Territorial Health Officers,
Marcus Plesha, present.
Biotechnology Industry Organization,
Phyllis Arthur, present.
Council of State and Territorial Epidemiologists,
Chris Hahn, State Epidemiologist for Idaho, present.
Council of State and Territorial Epidemiologists alternate if present. Canadian National Advisory Committee on Immunizations,
Carolyn Quash, present.
Infectious Diseases Society of America.
They'll be joining late.
Thank you. International Society for Travel Medicine,
Elizabeth Barnett, present.
National Association of County and City Health Officials,
Matt Zahn, present.
National Association of County and City Health Officials alternate if present. National Association of Pediatric Nurse Practitioners,
Not
National
present.
Association of Pediatric. I'm sorry, I was speaking over whoever that was.
This is Amanda. I was just saying they're not on.
Thank you very much. National Foundation for Infectious Diseases,
Carol Baker just indicated that she is present and unable to mute the phone from IDSA.
thank you very much. Carol Baker present. National Foundation for Infectious Diseases, one more time. Is the alternate present?
You can go ahead, Jose.
Yep. Sorry, this is Marla Dalton, present.
Thank you. National Medical Association,
Chad Whitley Williams, present.
Pediatric Infectious Diseases Society,
Sean O'Leary, present.
Pediatric Infectious Diseases Society alternate, Pharmaceutical Research and Manufacturers of America,
Corey Robertson, present.
Society for Adolescent Health and Medicine,
Amy Middleman, present.
Society for Healthcare Epidemiology of America.
Marcy Dries, present.
Is there anyone I missed on the roll call in any of the areas?
Jose, this is Amanda. One of our voting members, Kathy Paling, Dr. Paling is able to join in. Dr. Paling, can you indicate that you're present?
Kathy Paling, present, no conflicts, and Professor of Pediatrics at Wake Forest School of Medicine. Thank you.
Great. And Dr. Romero, I would like to quickly review for all of the liaisons and ex officios how to raise your hand on the Zoom call. If you are looking at the screen, you will see a participants box at the bottom of the screen with two little people. Click on that box and you'll see the participants show up in a sidebar. At the bottom of that sidebar is a list of signals below that say raise hand, yes, no, and it's that button that you press raise hand. So hopefully those instructions helped. And if you are having issues, please let us know. I'm also seeing a message from Dr. O'Leary from Pediatric Infectious Disease Society that he is present and was unable to unmute. I apologize for this being a little more complicated. Thanks, Dr. Romero.
Thank you. So I believe at this point, Dr. Messonnier wanted to address the ACIP.
Great. Thank you, Jose, and thank you, Dr. Cohn. Good morning, everybody. Thank you for joining us at our first virtual ACIP meeting. I'd like to thank the ACIP members, the ex officio members, the liaisons, the rest of the audience that is listening to us today. I'd especially like to thank the CDC team, both our regular ACIP team and all the folks that are supporting us today. I know this won't go off without hiccups, but we certainly appreciate the village that it takes to pull off this kind of meeting. Before we get started today, I'd like to take a moment to speak to you about the events that are taking place in our country. Over the last few months, we've been battling a pandemic, its economic consequences, and the painful reality of racial injustices and inequities. Like many of you, I feel overwhelmed by these circumstances. However, we cannot ignore the racial injustice, systemic racism, and their impact in the longstanding racial disparities in healthcare and public health in the United States. The lack of diversity in organizations across multiple sectors, including scientific and medical pursuits, is mirrored in our healthcare system, where significant health disparities exist in certain communities. COVID-19 is just the latest in a long list of diseases that underscores the health inequities in the African American community. In order to close the health disparity gap, there is much more that needs to be considered when designing and implementing our public health work. There is also much more to do within our own organizations to increase diversity and provide more opportunity for our peers who are Black, Hispanic, and from other racial and ethnic minority groups. It's important to mentor, recruit, and retain the next generation of scientific leaders who reflect the communities we serve, especially in and from the communities who bear the burden of many health inequities. At NCRD, we are working through programs like the Morehouse College Imhotep program to build the pipeline of racial and ethnic minority candidates for our flagship programs like EIS. And we are committed to improving our workplace diversity and inclusiveness so that all staff feel welcomed, fully engaged, and supported. We must also develop, enhance, and maintain strong partnerships, which are vital in implementing our public health programs. We are continuing funded partnerships with groups like the National Association for Community Health Centers, and we're strengthening existing partnerships to improve connections between state immunization programs and state health equity directors. I want to close by saying how much I appreciate the dedication and perseverance of our CDC staff and our many partners who continue the critical daily work of protecting people and saving lives despite the extreme turbulence and uncertainty right now. We are a country founded on the ideals of opportunity and equality, and as physicians, scientists, and public health professionals, we have a real responsibility to live up to those values. Let's double down on our commitment to improve health outcomes for all people. I challenge everyone in the vaccine space to listen, create opportunities for open and honest dialogue, and to do your part to support, recruit, and retain the most diverse workforce possible, especially in our scientific leadership positions. While the events happening in our country are extremely painful, there is signal to those of us in leadership positions to chart a better path forward, starting now. Thank you.
Thank you very much. I will now turn this back over to Dr. Cohen to begin the meeting. Go ahead, Dr. Cohen.
Great, thank you. And we have gotten some messages that a couple of additional people are having trouble with their phone lines. Susan Lett is on the line as well right now, just for your awareness. I think we'll go ahead and get started with the meeting. We appreciate you all. We appreciate that it took a little bit of extra time to get through that, but we'll start with the meningococcal session this morning, and we'd like to introduce Ms. Veronica McNally, who is the chair of the Meningococcal Vaccines Workgroup.
It's my pleasure today to introduce the meningococcal vaccine session. A new meningococcal serogroup, ACWY vaccine, MenACWY-TT, MenQuadfi, was approved by the FDA in April of 2020. It's approved for use in individuals aged greater than or equal to 2 years. The issue under consideration is whether MenACWY-TT should be available as an option for MenACWY vaccination according to currently recommended dosing and schedules in the Vaccines for Children program. Next slide. This is a VFC vote. The vote will address whether MenACWY-TT should be included as an option for meningococcal serogroup A, C, W, and Y vaccination in the Vaccines for Children program according to currently recommended dosing and schedules. No ACIP vote is needed as no changes to recommendations are proposed. Next slide. Meningococcal disease is a serious infection that can progress rapidly. 1 in 10 patients die despite antibiotic treatment, and among survivors, 1 in 5 have long-term sequelae, which can include hearing loss, amputations, and cognitive deficits. Next slide. The incidence of meningococcal disease is at an all-time low in the United States, with 0.10 cases per 100,000 population in 2018. Serogroup C, W, and Y combined currently account for approximately 50% of all cases. Next slide. MenACWY vaccines have been recommended for adolescents and persons at increased risk since 2005. 3 MenACWY conjugate vaccines are currently available. These are MenACWY-D, MenACTRA, MenACWY-CRM, MenOVO, and the new MenACWY-TT, MenQuadfi. Next slide. The populations currently recommended for MenACWY vaccination are adolescents with 1 dose at 11 or 12 years of age and a booster at age 16 years. Vaccination is also recommended for persons greater than or equal to 2 months of age who are at increased risk for meningococcal disease due to specified underlying conditions or exposure. Next slide. The Meningococcal Vaccines Workgroup reviewed data on MenACWY-TT safety, immunogenicity, persistence of immune response, and concomitant administration with other vaccines, and used GRADE along with evidence to recommendations framework to assess use of MenACWY-TT as an option for MenACWY vaccination. Next slide. Today, our agenda includes a presentation from Corey Robertson of Sanofi Pasteur on the safety and immunogenicity of MenQuadfi. Lucy McNamara will present the evidence to recommendations framework, GRADE, and workgroup considerations. And finally, Frank Whitlatch will present the Vaccines for Children resolution language. Next slide. I would like to acknowledge and thank our workgroup members, including ACIP member Hank Bernstein, the ex officio members Lucia Lee, Anuja Rastogi, and Ruth Brenner, and of course our CDC lead, Lucy McNamara, as well as the liaison representatives and consultants. Next slide. And finally, thank you to all the CDC contributors listed here. Next slide. Thank you.
Thank you very much, Ms. McNally. So next, we'll call Dr. Robertson to present safety and immunogenicity of MenQuadfi.
Thank you for the introduction, and thank you for this opportunity to provide information on Sanofi Pasteur's newest MenACWY vaccine, MenQuadfi. So I wanted to start out with outlining what I plan on presenting over the next 15 minutes. I want to take a moment to again remind us all of the public health importance of meningococcal disease. Then I'll provide an overview of MenQuadfi, including the key safety and immunogenicity data that led to the vaccine's licensure in the US. And then I'll end with a summary and some additional considerations for MenQuadfi. So as Ms. McNally already pointed out, meningococcal disease still poses a public health challenge given this high case fatality rate and that many survivors are left with serious permanent sequelae. Thankfully, MenACWY vaccines have been effective at preventing the disease. Since the introduction of the first MenACWY, MenACTRA in 2005, followed by Menveo in 2010, invasive meningococcal disease caused by serogroup C, W, and Y has declined by more than 90% among adolescents and young adults. But even so, there's still room for improvement when it comes to MenACWY vaccination, including an opportunity to expand protection to both ends of the age spectrum with a single vaccine. And with this in mind, MenQuadfi was developed. MenQuadfi is a quadrivalent meningococcal conjugate vaccine designed to help prevent invasive meningococcal disease caused by serogroups A, C, W, and Y. In April of this year, the FDA approved the vaccine for use in persons 2 years of age and older, including adults 56 and up. And this is a segment of the US population for whom, up until now, no licensed meningococcal conjugate vaccine existed. MenQuadfi was developed with the ambition of being used in a broad age range, and Sanofi Pasteur is currently conducting ongoing trials to look at the performance of MenQuadfi in children as young as 6 weeks of age. In those same studies, we're looking at MenQuadfi in different dosing intervals with the hopes of it being incorporated in the various immunization schedules that exist worldwide. MenQuadfi contains tetanus toxoid as a protein carrier, and each 0.5 ml dose contains 10 micrograms each of the 4 polysaccharide antigens contained in the vaccine. MenQuadfi will be supplied in a single dose vial as a fully liquid formulation or solution that doesn't require reconstitution. This table is a summary of the clinical trials that comprise the development program which led to the initial licensure of the vaccine in the US. In the first 3 trials, MenQuadfi was evaluated in adolescents, older adults, and as a booster. And in the last 2 trials, MenQuadfi was evaluated in children 2 through 9 years of age and persons 10 through 55 years of age. These were the comparators used in the clinical development program. They included MenACWY-CREM, or MENVIO, MPSV4, the plain polysaccharide vaccine known as MenImmune, and MenACWY-D, MenACTRA. I just want to take an opportunity to provide a couple of summary statements here. So all trials were randomized, blinded, and active control. And due to randomization, demographic characteristics were well balanced across vaccine groups within each of the respective trials. Study populations for each trial reflected the racial and ethnic diversity of the US population to varying degrees. And results of 4 of the 5 trials have been published in the medical literature. A manuscript for the remaining trial is currently under review. So let's begin by discussing MET50. This was a study of over 1,700 adolescents 10 through 17 years of age, and they were randomly assigned to 1 of 4 vaccine groups. Group 1 received MenQuadfi, Group 2 received the comparative MenACWY-CREM, Group 3 received MenQuadfi along with Tdap and HPV, and Group 4 received concomitant Tdap and HPV without MenQuadfi. The mean age of the study population was just over 11 years. Looking at safety, what I'm showing you here are the frequency of solicited reactions by vaccine group. Those following when MenQuadfi was given alone are shown in dark blue. When MenACWY-CREM was given alone, light blue. MenQuadfi along with Tdap and HPV, that's shown in dark pink. And the frequency of reactions when Tdap and HPV were given concomitantly without MenQuadfi, that's shown in green. You can see that the frequency of solicited reactions were similar across the different vaccine groups, except for myalgia, which occurred at a higher frequency in the concomitant vaccination groups that included Tdap and HPV. Turning to immunogenicity, MenQuadfi, which is shown in dark blue, induced seroresponse rates that were non-inferior to the comparative vaccine shown in light blue. Point estimates were consistently higher across the different vaccine serogroups, and confidence intervals, 95% confidence intervals, were non-overlapping. The same pattern was seen with respect to seroprotection rates and with respect to post-vaccination GMTs, including a pretty pronounced response to serogroup C relative to the comparative vaccine. In this and the next few slides, I'll be showing you immune responses associated with concomitant vaccination. Here we're looking at post-vaccination GMTs with respect to serogroups A, C, W, and Y. Responses following MenQuadfi when it was given alone are shown in blue, and when it was given with Tdap and HPV, those are shown in yellow. And within the green boxes, you'll see the geometric mean titer ratios. And because those values all hover around 1, it indicates that concomitant administration of Tdap and HPV did not have a material impact on MenQuadfi's immunogenicity. Likewise, when MenQuadfi was given with Tdap and HPV, MenQuadfi did not have a material impact on the responses following HPV vaccination as assessed by seroconversion rates. Looking at the Tdap component, seroprotection rates following concomitant MenQuadfi, Tdap, and HP vaccination were not inferior to the seroprotection rates observed after Tdap and HPV without MenQuadfi. Now looking at the pertussis component, non-inferiority of pertussis antibody responses was considered met at the lower bound of the 95% confidence interval around the geometric mean concentration ratio of group 3 over group 4 was greater than 0.667. Based on that definition, non-inferiority was met for the PT antigen and narrowly missed for FHA and pertactin. Lower antibody responses to pertussis antigens have been observed in other trials where meningococcal vaccines have been co-administered with pertussis-containing vaccines. The clinical significance of any of this finding is unknown, especially since no antibody correlative protection exists for pertussis. Now moving on to the study of MenQuadfi in adults 56 years of age and older. In MET49, over 900 persons in this age group participated. They were randomly assigned to receive either MenQuadfi or the plain polysaccharide vaccine, MenImmune. The mean age of the study population was just over 72 years. Rates of solicited reactions were higher in the MenQuadfi group compared to the plain polysaccharide group. And there's likely 2 reasons for this, especially when you look at injection site reactions. 1, MenQuadfi does contain tetanus toxoid as its protein carrier. And 2, MenQuadfi is administered intramuscularly, whereas the plain polysaccharide vaccine is administered sub-Q. In terms of immunogenicity, MenQuadfi induced seroresponse rates that were non-inferior to those induced by the comparator vaccine. Again, point estimates were consistently higher, and in this case, 95% confidence intervals were non-overlapping. A similar pattern was seen with respect to seroprotection rates, but with the exception of serogroup A, 95% confidence intervals were non-overlapping. And once again, MenQuadfi induced geometric mean titers that were higher than those induced by the comparative vaccine, especially for serogroup C. Now moving on to MET56. This was a study of MenQuadfi when used as a booster. In this trial, over 800 participants, 15 years of age and older, participated. And to be eligible for participation, they had to be primed with either MenACWY-D or MenACWY-CRIM. They were randomly assigned to receive either MenQuadfi as a booster or MenACWY-D as a booster. The mean age was 20 years. Injection site reactions and systemic reactions were similar between the 2 vaccine groups when they were used as boosters. And MenQuadfi as a booster induced seroresponse rates that were non-inferior to MenACWY-D when used as a booster. Both vaccines induced high seroprotection rates, ranging between 99 and 100%. And both vaccines induced robust booster responses, but especially MenQuadfi, and especially so for serogroup C. I just want to touch on the other two trials I mentioned, MET35 and 43. In MET35, MenQuadfi was evaluated in children 2 through 9 years of age. 1,000 children participated in this trial. Half were randomly assigned to receive MenQuadfi, and the other half MenACWY-TT. The mean age of the study population was 6 years. Frequency of solicited reactions were similar between the two vaccine groups, except that there was a slightly higher trend towards a higher frequency of injection site reactions among those who received the comparator. MenQuadfi induced seroresponse rates that were non-inferior to the comparator vaccine. Again, point estimates were consistently higher, and with the exception of serogroup A, 95% confidence intervals were non-overlapping. The same pattern was seen with respect to seroprotection rates. And with respect to GMTs, again, you also see the more pronounced response to serogroup C. And finally, MET43, this was a study of MenQuadfi in adolescents and adults 10 through 55 years of age. Over 3,300 persons participated in this trial, and they were randomly assigned to receive either MenQuadfi from 1 of 3 vaccine lots or MenACWY-TT. The mean age of the study population was just over 27 years. Solicited reactions occurred with similar frequency between the two vaccine groups, the two vaccines. MenQuadfi, once again, this is probably a pattern you're used to seeing by now. MenQuadfi induced seroresponse rates that were non-inferior to those induced by the comparator vaccine. Once again, point estimates were consistently higher with non-overlapping confidence intervals, and the same pattern was seen with respect to seroprotection rates. And with respect to post-vaccination GMTs, and again, you see the more pronounced response to serogroup C. So in closing, MenQuadfi was demonstrated to be safe and induce a robust immune response against serogroups A, C, W, and Y, especially serogroup C. And immune responses were consistently non-inferior to those induced by standard of care vaccines across all age groups 2 and older, and for all 4 vaccine serogroups. MenQuadfi also induced booster responses among persons previously primed with either MenACWY-TT or MenACWY-TT. And clinical trial data show that MenQuadfi can be co-administered with routinely recommended adolescent vaccinations, namely Tdap and HPV. Now that MenQuadfi has been licensed, Sanofi Pasteur will be distributing doses of the vaccine next year to help support meningococcal vaccination efforts in 2021. And as I mentioned before, trials are ongoing to seek expansion of the age indication down to children 6 weeks of age. And in those studies, we're looking at MenQuadfi in a number of different dosing intervals and along with other routinely recommended pediatric vaccines, again, with the hopes of MenQuadfi being incorporated into different immunization schedules that exist around the world. And I just want to end by saying that we believe MenQuadfi has the potential to provide effective protection against invasive disease caused by serogroups A, C, W, and Y in a variety of settings. So that concludes my presentation, and I thank you for your time.
Thank you very much, Dr. Robertson. So now we'll open this up to questions from the voting members. Normally, I would look to my left and see a list of questions in the order your hands are raised. I'm going to ask Dr. Cohen to let me know who's on the list to ask questions. Dr. Cohen, anybody?
I'm sorry for the echo, folks. I wondered if Sanofi could comment about their plans for the availability of MenACWY-TT.
I'm sorry, Dr. Messonnier, you sound very far away.
I'm sorry. I was asking whether Sanofi could comment about their plans for MenACWY-TT and whether that vaccine will continue to be available?
Thank you for the question. So the plan is for us to transition from MenACWY to MenQuadfi, but given that MenACWY is registered in over 70 countries, that transition will take some time, and certainly it won't happen before we achieve age indication that we're shooting for down to 6 weeks of age. So the plan is to eventually have MenQuadfi replace MenACWY, but like I said, the transition will be taking some time.
So scanning down the list of participants, I see no one with their hand raised. Dr. Cohn, is that correct?
No, Dr. Romero, Dr. Bernstein has his hand raised.
Okay, go ahead, Dr. Bernstein.
Yeah, I may have misinterpreted a slide. On slide 11, where there were comparisons to the various meningococcal vaccines and given with Tdap and HPV, I noted that there were no injection site reactions at all for the group that received Tdap and HPV?
No, not that there weren't any injection site reactions. The way this study was designed, we were looking at injection site reactions specifically related to the MenACWY groups. So that's why those aren't reported in the slide. It's not to say that they didn't have any injection site reactions.
So we don't have a baseline for that. Okay, thank you.
Dr. Cohn, is there anybody else that I'm missing?
Nope, there are no additional questions. Oh, excuse me, Dr. Freihofer has a question.
Oh, Dr. Freihofer, please go forward.
Yes, Sandra Freihofer, American Medical Association. So this is this has a tetanus toxoid in it. So how does that affect tetanus vaccination, and how does that affect reactions when patients also get maybe a TD or Tdap? This is similar, I guess, to the previous question, but how does it affect boosters?
So as shown on this slide, reactions with respect to concomitant vaccination with MenQuadfi and Tdap, outside of my allergen, rates are similar. So here, so when MenQuadfi was given with Tdap, no impact on tetanus and diphtheria responses. And if you go to the next slide, as I mentioned before, when we looked at non-inferiority of pertussis antibody responses, non-inferiority was met for one of the four antigens, and there was a marginal miss for the other two antigens to the right. And again, this type of antibody response has been observed in other studies where meningococcal vaccine has been given with pertussis-containing vaccines. We don't anticipate this to be an issue clinically because we also looked at several vaccine response with respect to these antigens, and across the board, they were high.
We have one more question from Dr. Hunter.
Go ahead, Dr. Hunter, please.
And before I leave, I should add that the data that I've presented is also in the manuscript that was published.
Thank you.
Yep.
This is Paul Hunter. I'm following up on Sandy Freihofer's comment. I think she may have, or at least the way I interpret what she was asking is, if you give multiple doses of tetanus vaccine, after several of them, you'll get a stronger local swelling and pain at the injection site, which can be significant after, I forget, 5, 6, 7 doses, whatever it is. And I guess that's the question I would have is, especially if you were to do this in series with, over multiple times in a person's lifetime, are they going to get significant local reactions? Obviously, it's not going to be dangerous, so usually, but it would be quite painful, possibly, in a small number of people. I'm just wondering if that had occurred in any of the studies.
So in the studies, we don't have data where Tdap or TD was given repeatedly as boosters along with MenQuadfi, so that's something we would certainly monitor for in the future.
Thanks.
Yep.
Again, scanning, I don't see anybody. Dr. Cohn, is there somebody I'm missing?
Dr. Romero, we're done with questions. We can move on to the next session, to the next speaker.
Very good, thank you. So we'll now move on to Dr. McNamara, who will present the MenACWY-TT evidence, the recommendations, grade, and work group considerations. Dr. McNamara, please.
Thank you. Good morning. All right, so I'll begin this presentation with a brief overview of current serogroup ACWY or MenACWY vaccine recommendations and available vaccines. Then I'll review our policy questions and the evidence to recommendations framework for inclusion of MenACWY-TT as an option for meningococcal ACWY vaccination. I will briefly touch on all of the points in the ETR, but will focus on the benefits and harms section, including grade. Finally, I'll review the considerations and conclusions of the meningococcal vaccines ACIP working group on this issue. So very briefly, this slide shows the MenACWY vaccines that will be referenced during this presentation. Note that the first two in the table, MenACWY-D and MenACWY-CRM, are the vaccines that are currently in use in the US. Next is MenQuadfi. Please note that while MenQuadfi was referred to as MenACY-WTT by the manufacturer, for consistency, we are using MenACWY-TT. MenImmune or MPSV4 is no longer available in the US, and Nimenrix or MCV4TT has never been licensed in the US. While MenQuadfi and Nimenrix are both tetanus toxoid conjugate vaccines, they have different amounts of meningococcal antigens and tetanus toxoid carrier protein. And as a reminder, here are the current ACIP recommendations for use of MenACWY vaccine in the US. 2 doses of MenACWY are recommended for adolescents at 11 to 12 and 16 years. Other individuals at increased meningococcal disease risk, due either to underlying medical conditions or to increased exposure, are also recommended to receive meningococcal vaccines, including boosters for those who remain at increased risk. So the question we are addressing in this session is, should MenACWY-TT be included as an option for meningococcal ACWY vaccination according to currently recommended dosing and schedules? The population would be persons aged greater than or equal to 2 years who are currently recommended to receive meningococcal ACWY conjugate vaccines. The intervention is vaccination with MenACWY-TT according to currently recommended dosing and schedules. The comparison is vaccination with MenACWY-D or MenACWY-CRM according to currently recommended dosing and schedules. And the outcomes are development of serogroup A, C, W, or Y meningococcal disease, short-term immune response, persistence of the immune response, immune interference due to co-administration with other routine adolescent vaccines, or serious adverse events. Currently, there are no data on vaccine effectiveness against serogroup ACWY meningococcal disease for MenACWY-TT. The remaining 4 outcomes in bold are included in the evidence profile: the short-term immune response and persistence of the immune response induced by the vaccine, immune interference due to co-administration with other routine adolescent vaccines, and serious adverse events associated with MenACWY-TT. The first element in the evidence to recommendations framework is the problem. ACIP has recognized the importance of meningococcal disease as a public health problem through existing vaccine recommendations. The workgroup felt that the question of whether to include MenACWY-TT as an option for meningococcal vaccination is of public health importance given recent licensure of this vaccine in the US and to support security of the vaccine supply. Now I'll move on to the benefits and harms of MenACWY-TT, including grade. For the evidence retrieval to examine benefits and harms, we conducted a systematic review of studies in any language from the listed databases using the search strings shown here. Efforts were made to obtain unpublished data. We included studies that presented primary data on MenACWY-TT. 149 references were identified in the database search. After screening the titles, abstracts, and articles or publicly available clinical trial results, 10 studies were included in the grade analysis. This table shows the 10 studies identified, all of which were phase 2 or 3 clinical trials conducted by the manufacturer. All 10 studies included safety data. 8 had immunogenicity data. 1 had persistence data. And 2 had information on co-administration. However, only one of these included co-administration of routine adolescent vaccines. Note that the data reviewed for grade did not include any data on individuals who are recommended to receive meningococcal vaccines based on underlying medical conditions, as these groups were excluded from the evaluated studies. So first I'll discuss short-term immunogenicity assessed 30 days after vaccination with MenQuadfi. As an example, here are the immunogenicity results for one study. The table shows for each serogroup the geometric mean titers, or GMTs, induced by MenACWY-TT and the comparator vaccine, and the GMT ratio, where the GMT for MenACWY-TT is divided by the GMT for the comparator. This means a GMT ratio of greater than 1 shows higher GMTs induced by MenACWY-TT. Next, the table shows the percent and absolute difference in percent seroresponders, calculated as the percent seroresponders for MenACWY-TT minus the percent seroresponders for the comparator. So a positive number shows a higher percent seroresponders with MenACWY-TT. You can see that MenACWY-TT elicited higher GMTs and a larger percent seroresponders than the comparator for all 4 serogroups, with the largest difference for serogroup C, a trend observed across all included studies. This table summarizes the 8 studies with data on short-term immune response. For each study, the range of GMT ratios and absolute difference in percent seroresponders is shown across the 4 serogroups. Across serogroups, age groups, and comparator vaccines, GMTs and percent seroresponders were nearly always higher among individuals who received MenACWY-TT, and all studies demonstrated non-inferiority of MenACWY-TT compared with the comparator vaccine. We evaluated the certainty of evidence using grade. Under this approach, certainty of evidence is rated on a 1 to 4 scale, with a 1 corresponding to randomized controlled trials or overwhelming evidence from observational studies, a 2 corresponding to RCTs with important limitations or exceptionally strong evidence from observational studies, a 3 corresponding to observational studies or RCTs with notable limitations, and a 4 corresponding to clinical experience and observations, observational studies with important limitations, or RCTs with several major limitations. So here is the grade table for short-term immunogenicity based on those 8 studies. For healthy children, adolescents, and adults, we felt there was no serious risk of bias, inconsistency, indirectness, or imprecision. The studies demonstrate that immune responses to MenACWY-TT are non-inferior to those induced by other licensed quadrivalent meningococcal vaccines with high certainty rated as a 1. For groups at increased risk due to underlying medical conditions, indirectness is considered very serious based on the fact that studies included only healthy individuals. The certainty for these groups is 3. The second grade outcome was serious adverse events, or SAEs. All 10 studies included data on SAEs. Reported rates of SAEs were generally low, and none of the reported SAEs were determined by the researchers to be related to the vaccine. The highest rates of SAEs were reported in toddlers, an age group for which the vaccine is not currently licensed in the US. The majority of these SAEs were accidental injuries or infections by pathogens not included in the study vaccines. For individuals aged 2 years and older, including booster dose recipients, rates of SAEs were similar in MenQuadfi and comparator groups. For grade, we included the 9 randomized studies with safety data. Risk of bias was considered serious because many trials were not fully double-blinded, which could lead to bias in assessing SAEs. In addition, the studies did not describe how the researchers determined that SAEs were not vaccine-related. There were no serious concerns for inconsistency, indirectness, or imprecision for use of the vaccine in healthy individuals, so overall certainty is moderate or 2. For people at increased meningococcal disease risk due to underlying medical conditions, indirectness was very serious as the studies included only healthy individuals, resulting in very low certainty of 4 for this group. One study evaluated immune persistence. This study was conducted in 4 to 5-year-olds vaccinated 3 years earlier with MenACWY-TT compared with Nimenrix or MCV4-TT. For serogroups C, W, and Y, GMT ratios are greater than 1, showing higher GMTs 3 years after vaccination with MenACWY-TT than with the comparator. The GMT ratio for serogroup A is less than 1. However, it should be noted that serogroup A is extremely rare in the United States. This was a descriptive analysis, so non-inferiority was not assessed. Grading the evidence from this one study, the risk of bias is serious because fewer than 50% of participants who received the primary vaccine dose were included in this follow-up persistence study. There is also serious concern for indirectness because the study was conducted in Finland in individuals vaccinated as toddlers, an age group for which MenACWY-TT is not approved in the US. Finally, there is serious concern for imprecision because of the small number of participants. Overall, this brings the certainty to a very low certainty of 4 for healthy individuals. For the groups at increased risk due to underlying medical conditions, indirectness is considered very serious because the study included only healthy individuals, but overall certainty remains the same at 4. Finally, we'll discuss data from one study on co-administration with routinely recommended adolescent vaccines, HPV and Tdap. For HPV, non-inferiority was demonstrated across all 4 included HPV types when comparing co-administration of MenACWY-TT, Tdap, and HPV vaccines to co-administration of just Tdap and HPV. For Tdap, non-inferiority was demonstrated for both tetanus and diphtheria antigens and for the PT pertussis antigen, but not for the pertussis FHA, PRN, and FIM antigens. Failure to meet non-inferiority for pertussis antigens included in Tdap has also been observed with co-administration of Tdap and other licensed MenACWY vaccines. This table compares the data shown on the previous slide with data from prior studies of MenACWY-CRM and MenACWY-D co-administration with Tdap. Numbers in red indicate antigens for which non-inferiority criteria were not met. The clinical significance of these findings is unknown, as there is no accepted correlative protection for pertussis vaccines. For grade, risk of bias in this one available study was classified as serious due to the reduced number of participants evaluated for HPV immunogenicity, for which no explanation could be identified in the published article. There were no serious concerns about indirectness or imprecision for healthy individuals, so overall certainty was a 2. For the groups at increased risk due to underlying medical conditions, indirectness is considered very serious based on the fact that studies included only healthy individuals, bringing overall certainty to a 4. While PCV13 is not a routine adolescent vaccine, and therefore we did not include co-administration issues with this vaccine as an outcome for grade, PCV13 is also recommended for individuals who are recommended to receive MenACWY because they have medical conditions that increase risk of meningococcal disease. One study assessed co-administration of MenACWY-TT and PCV13 in toddlers, and no evidence was found of immune interference between these vaccines. To summarize the grade assessment for healthy individuals, we rated the certainty of evidence as 1 for short-term immunogenicity, 4 for persistence, and 2 for co-administration of routine adolescent vaccines and serious adverse events. However, for people with medical conditions increasing their risk of meningococcal disease, quality of evidence was a 3 for short-term immunogenicity and 4 for the other outcomes. Overall, the work group felt that the desirable effects outweigh the undesirable effects, favoring inclusion of MenACWY-TT as an option for MenACWY vaccination. For the values, acceptability, and feasibility sections of the ETR framework, the work group felt that the 86.6% vaccination coverage in 2018 for at least 1 dose of MenACWY vaccine among adolescents demonstrates that the target population values and accepts this intervention and that it is feasible with current vaccination platforms. However, there are limited data on uptake among other individuals recommended to receive MenACWY vaccine, such as microbiologists or individuals with medical conditions that increase meningococcal disease risk. It is not expected that values, acceptability, or feasibility would differ for MenACWY-TT compared with currently available meningococcal conjugate vaccines. For resource use, the manufacturer has indicated that the projected cost of MenACWY-TT will be within 5% of the cost of currently licensed and available MenACWY vaccines, so resource allocation will not be substantively affected by inclusion of MenACWY-TT as an option for MenACWY vaccination. To summarize the ETR assessment, the work group felt that for the question of whether to include MenACWY-TT as an option for meningococcal ACWY vaccination, that the problem was of public health importance. While the desirable anticipated effects are small, the undesirable ones are minimal, therefore favoring intervention with a certainty of evidence that varies from high to very low across critical outcomes and populations recommended for vaccination. The work group believed that the target population does feel that the desirable effects outweigh undesirable effects, with probably no important uncertainty or variability in how much people value the main outcomes, that the intervention is acceptable to key stakeholders, that it is a reasonable allocation of resources, and that it is feasible to implement. Overall, it was felt that the desirable consequences probably outweighed undesirable consequences in most settings. The work group's interpretation was that there was sufficient information to include MenACWY-TT as an option for meningococcal ACWY vaccination according to currently recommended dosing and schedules. This would apply only for individuals aged 2 years and up, the ages for which the vaccine is licensed in the United States. The work group was in agreement on this. Of note, several of the current recommendations for use of MenACWY are off-label for all currently licensed MenACWY vaccines, including the 2-dose primary series for groups with specified underlying medical conditions, all booster doses among persons aged less than 15 years, and boosters beyond the first for individuals who are recommended to receive boosters every 3 to 5 years. For MenACWY-D and MenACWY-CRM, but not for MenACWY-TT, use in persons aged greater than 55 years is also off-label. Implementation of MenACWY-TT as an option for MenACWY vaccination does not represent a change in policy or ACIP recommendations, and therefore no ACIP vote is required. However, a VFC vote and updated VFC resolution are required to include MenACWY-TT as an option in the VFC program. Frank Whitlatch will discuss the updated VFC resolution in the next presentation. I want to thank the work group and other individuals listed here. Here for reference are the studies evaluated, and I'm happy to take any questions.
Thank you, Dr. McNamara. I will open it up now to the voting members to see if there are any questions or comments.
Dr. Romero, Dr. Paling has her hand raised.
Dr. Paling, please go forward.
Okay, so thank you for presenting this beautiful data and summarizing the work that's been done. It's a tremendous amount of work and really well done. I think the issue that you pointed out really clearly was that the ACIP vaccine is approved for children through adults, and it isn't approved for people less than 2 years of age. And I think that's really important because currently the children less than 2 do have a high risk of meningococcal vaccine. So it's going to be very important that moving forward that there still is a vaccine available for children 2 months to 2 years of age.
Thank you for those comments. Anyone else from the voting members who has a question?
Dr. Lee has her hand raised.
Dr. Lee, go.
Yes, thank you. I actually didn't raise my electronic hand soon enough for the last presentation, but I just wanted to recognize and reflect on the fact that the trials actually incorporated racial and ethnic diversity that was representative of the population. I just wanted to call that out and appreciate that. And I realized we didn't comment on that, which I hope we get to a point where we don't need to comment on that because that becomes the norm. But I think that becomes really important for us in current and future conversations. So thank you.
Thank you for that comment. Anyone else from the voting membership that wishes to make a comment?
Dr. Sanchez has his hand raised.
Dr. Sanchez, please.
Yes, hi. This is a comment. I think that the lower pertussis antibody titers for certain antigens, to me, are of concern as we see more pertussis disease in the United States and outbreaks. So I know that we don't have any defined protective levels, but I think that's something that needs to be studied when given, concomitantly in the future.
Thank you for those comments. Anyone else on the voting membership list that wishes to make a comment? Don't see any of the liaison members, representatives, or ex officio members.
Dr. Barnett.
Dr. Mardet, please.
Yes. Serogroup A disease may be very rare in the United States, but it is one of the most common for travelers. And did the working group express any concern about the lower GMT response for serogroup A?
Thank you. So the lower GMT response for serogroup A that I mentioned was specifically for the persistent study where MenQuadfi was being compared with Menrix, which is a vaccine that's not currently licensed in the US. In most of the studies looking at short-term immunogenicity, or actually in all of the studies, non-inferiority was demonstrated for the short-term immune response for all serogroups for MenQuadfi compared to the vaccines currently available in the US.
Great. Dr. Freihofer has her hand raised.
Dr. Freihofer, please.
Yes, Sandra Freihofer, American Medical Association. So a little bit of the same sort of question I had before. So this is conjugated to tetanus toxoid, but this in no way affects getting tetanus boosters. Does it provide any protection against tetanus? I just wanted to clarify that for practicing clinicians.
So the vaccine is licensed for protection against meningococcal disease. I don't believe that the ability of the vaccine to protect against tetanus has been assessed.
So we have taken the opportunity to look at anti-tetanus responses, and they are on par with levels that you would see as being seroprotective. However, as was mentioned, this vaccine is not indicated for use for prevention of tetanus. But the responses that we've seen were on par with seroprotective levels.
Thank you. Anyone else? Or Dr. Freihofer, do you have more to ask?
Thank you for that clarification.
Anyone else?
Dr. Romero, I think we can move to the Vaccines for Children resolution.
Yes. Dr. Whitlatch, would you please present the VSC resolution update And then for the voting members, we'll need, if appropriate, a motion to accept, then a second. There will be no vote until after the public comment section. Please go forward.
Thank you. I am presenting the VFC resolution update for meningococcal vaccines. Yellow font and yellow highlights in the presentation is used to indicate changes to the resolution in comparison to the prior approved version. The purpose of this resolution is to update the resolution to reflect currently available meningococcal conjugate vaccines that can be used to prevent meningococcal disease attributable to serogroups A, C, W, and Y. The first section of the resolution is for serogroups A, C, W, and Y. There have been no changes made to the eligible groups. A new table has been added to summarize all vaccine types covered by this section of the resolution. The resolution did not previously include a table. The MenACWY and MenVeo information reflects previously published ACIP recommendations, and the MenQuadfi information is new. The links to the recommended schedules and intervals have not changed, and the recommended dosage and contraindications and precautions have not changed. This section of the resolution is for serogroup B. The eligible groups have not changed. The recommended vaccination schedule and intervals has not changed. The recommended dosage and the contraindications and precautions has not changed. And finally, the statement regarding updates based on published documents has not changed. Thank you.
Thank you very much. Are there questions from the voting members? Comments?
I want to remind everyone that they have a Word document of this Vaccines for Children resolution, and the voting members have one in their background documents.
If there are no comments or further questions, may I have a motion to accept the VSC resolution update for meningococcal vaccines?
Dr. Szilagyi?
Move to accept the VSC resolution.
Thank you, Dr. Szilagyi. Move to accept. May I please have a second?
Dr. Paling?
Dr. Paling, please.
I make a motion to accept the proposal.
Thank you.
Thank you very much. I'm sorry, the second proposal.
Yes. Thank you. Are there any other comments or questions? All right, very good. Then we will vote on this after the public comment section. So let's move on to the influenza vaccines. Dr. Robert Admar will give the introduction. Dr. Admar, if you please.
Thank you, Dr. Romero. If I could have the second slide.
I'm going to take this second while we're pulling up the slides to thank all of you on the West Coast who we forced to wake up extremely early this morning. I hope by now you guys are well awake and have had some coffee, but we will not start future ACIP meetings that are virtual this early. Apologies.
All right, so I want to start by acknowledging the members of the Influenza Workgroup, including my fellow ACIP members, Drs. Alt, Bernstein, Szilagyi, and Talbot, our ex officio members, consultants, and liaison representatives who are all listed here, and of course, our lead, Dr. Groskopf. Next slide, please. Thank you. So the last session of the ACIP in February, during that session, we gave an overview of the early 2019-2020 season influenza activity. We reviewed early season 2019-20 influenza vaccine effectiveness and provided estimates for the vaccine effectiveness. There was a presentation from Securus, a pre-licensure study of quadrivalent adjuvanted inactivated influenza vaccine, Fluad quadrivalent, and that vaccine was licensed by the FDA in February of this year. And then there was a presentation of safety data from a comparative randomized controlled trial of high dose and adjuvanted inactivated influenza vaccines among older adults. Next slide. Recent work group activities have included development of the proposed 2020-2021 ACIP influenza statement. Next slide. And the agenda for the influenza session today will be a review of the 2019-2020 influenza activity, vaccine effectiveness and safety updates. Work group considerations will be presented, and the 2020-2021 recommendations for vaccination and changes that have been proposed will also be presented, and we'll have a vote. Next slide. And so Dr. Grosskopf now will present the next session, our next presentation.
Dr. Grosskopf, if you please.
Thank you. Good morning, everybody. Thank you very much. Okay. So in addition to the work group members listed on Dr. Atmar's slide, we want to thank the many CDC personnel who attend our work group calls and who in many other ways contribute to our work on an ongoing basis. Next slide. This talk has a few parts. First, some updates concerning 2019-20 influenza activity, preliminary influenza vaccine effectiveness estimates, and an influenza vaccine safety update. Then we'll go over workgroup considerations and the proposed recommendations for the 2020-2021 influenza season. First, we'll start with the 2019-20 influenza activity update. Starting with virologic surveillance, these are results of influenza positive tests reported to CDC weekly. Data from the clinical labs are on the left and the public health labs on the right. For the clinical labs, influenza A viruses are in yellow and B viruses are in green. Influenza B viruses predominated early in the season, but with time we had an increasing presence of the influenza A viruses such that by the end of the season, taken as a whole, identified specimens were roughly divided between influenza A and B viruses. On the right with the public health labs, we get a little more information since they generally provide subtype and lineage. A viruses are in orange for the H1N1 PDM09 viruses and red for H3N2. B viruses are in light green for Victoria and dark for Yamagata. Overall, you can see that the predominant virus groups were H1N1 PDM09 and B Victoria. An additional point going back to the clinical labs on the left, the solid black line represents the percent of specimens that were positive. Note that this percentage was dropping steeply from about week 8 to week 12 or 14 of 2020. Moving on to surveillance for influenza-like illness, or ILI. These data are from ILINet, a network of providers who report weekly the percent of outpatient visits that were for ILI. Several seasons are represented on the graph. The most recent, 2019-20, is the red line with the triangles. There was relatively high ILI activity from late December through February with 2 separate peaks. Then there was a third peak. Because this is ILI, which uses a symptom or syndromic-based definition rather than lab confirmation of influenza, other pathogens besides influenza could be involved. By the time of this third peak, we know from other surveillance indicators, including what we mentioned on the previous slide, that influenza was still circulating, but activity had already begun to fall pretty dramatically. We also know that SARS-CoV-2 activity was increasing at that time, and so we assume that the third peak is due in large part to COVID-19 illness rather than influenza-related ILI. Next, on to influenza-associated hospitalizations with data from FluServe-Net. This chart shows cumulative hospitalization rates per 100,000 population for lab-confirmed influenza or associated with lab-confirmed influenza by calendar week. Each colored line represents a different season. The most recent, 2019-20, is in red. This line shows hospitalizations that occurred between October 1st, 2019 and April 30th, 2020. For this period, the cumulative hospitalization rate was approximately 69 per 100,000 population. This is considerably less than we saw in the pretty severe 2017-18 season, represented by the uppermost curve, but is still higher than the recent non-pandemic season shown. Oops. Next, influenza-associated mortality. The data on the left from the National Center for Health Statistics come from death certificate diagnostic reports and are reported as the percent of deaths due to pneumonia and influenza-coded diagnoses. So this is diagnostic code data and not laboratory-confirmed influenza. Again, calendar week is on the x-axis. Several seasons are in the figure, with the most recent on the far right. For the earlier part of the season, values were relatively low, but then we have a large peak in pneumonia and influenza deaths in the latter part of the season. This is thought to be largely due to COVID-19. The figure on the right shows pediatric mortality associated with laboratory-confirmed influenza, which has been reportable since 2004. As of the most recent reporting week, 185 pediatric deaths were reported to CDC for the 2019-20 season. This is unfortunately fairly close to the 188% reported for 2017-18. Among these deaths, 71% were associated with influenza A viruses and 114 influenza B viruses. In general, for the past number of seasons with these data, among those children who are eligible for vaccination and for whom vaccination information is available, the majority are not vaccinated, generally around 20%. Thus far, with the data that we have, that is looking similar, around 20% vaccinated this season, with the majority not vaccinated. For the past several seasons, CDC has published estimates of influenza burden in the United States. These preliminary estimates are on this slide, and they cover the period October 1, 2019 through April 4th, 2020. Estimates are that there were between 39 million and 56 million influenza illnesses, between 18 million and 26 million influenza-associated medical visits, between 410,000 and 740,000 influenza-related hospitalizations, and between 24,000 and 62,000 influenza-related deaths. Our next section is a summary of preliminary 2019-20 influenza vaccine effectiveness estimates from the U.S. Flu VE network. These estimates reflect data as of June 9th, 2020. As described previously, the U.S. Flu VE network is a network of 5 healthcare organizations for which the locations and principal investigators are shown on this slide. At these sites, the network enrolls outpatients aged 6 months and older with acute respiratory illness with cough of less than or equal to 7 days duration. Dates of enrollment were October 29th, 2019 through March 26, 2020 for the data that I'm presenting today. The network uses a test-negative design which involves comparing vaccination odds among influenza RT-PCR positive cases and RT-PCR negative controls. Vaccination status is defined as receipt of at least 1 dose of any 2019-20 seasonal influenza vaccine according to medical records, immunization registries, and/or self-report. VE is calculated as 1 minus the adjusted odds ratio times 100%. Adjustments are made for study site, age, sex, self-rated general health status, race and Hispanic ethnicity, interval from onset to enrollment, and calendar time. Here are the preliminary results for this season. 8,844 patients were enrolled. 2,743, or 31%, were RT-PCR positive for influenza. 6,121, or 69%, were RT-PCR negative. Among those who were PCR positive, the breakdown by influenza virus type, subtype, and lineage is shown in the pie chart. About half, or 51%, were influenza A H1N1 PDM09, 44% were B Victoria. There was relatively little in the way of H3N2 and B Yamagata viruses. Here are the preliminary VE estimates. Overall, across age groups, estimated VE was 39% for any influenza, 31% for influenza AH1 PDM09, and 44% for influenza B Victoria. All of these estimates are statistically significant. Looking at VE against H1N1 PDM09 viruses by age group, we see statistically significant VE of 45% among adults aged 50 through 64. The VE point estimate was a little lower at 38% for those aged 65 and older, and the lower limit for that estimate of the confidence interval is 0. Estimated VE was lower in the 22 to 29% range for younger adults and for children, and was not statistically significant for either of the pediatric age groups. For influenza B Victoria viruses by age group, VE point estimates were similar across the age groups in the 38 to 44% range and were statistically significant among children and young adults. They were not statistically significant for those aged 50 years and older. In summary, for this section, preliminary results for the 2019-20 season indicate 39%, 95% confidence interval, 32 to 45%, vaccine effectiveness against medically attended influenza. Vaccine provided important protection against influenza B viruses, given the severity of the 2019-20 season for children. Protection against influenza A, H1N1 PDM09 viruses was lower than in previous seasons, and investigation of contributing factors for these results is ongoing. Finally, note that preliminary end-of-season estimates use best available information on vaccination status of the participants at the time presented. These estimates will be revised as data are finalized. Next section, we normally have an end-of-season safety update in June, so next I have a few slides concerning 2019-20 season influenza vaccine safety. First, a brief disclaimer, or two. We'll start with a brief summary of 2019-20 influenza vaccine safety surveillance. Approximately 174.5 million doses of influenza vaccine were distributed in the United States through February 28, 2020. CDC and FDA analyzed spontaneous reports to the Vaccine Adverse Event Reporting System, or VAERS. No new safety concerns were identified for any influenza vaccine types. In addition, CDC conducted near real-time sequential monitoring through rapid cycle analysis in the Vaccine Safety Data Link, or VSD. Approximately 5.8 million doses of influenza vaccine were administered at VSD sites through March 7, 2020. No new safety concerns were identified for any influenza vaccine types in this analysis. We also wanted to let you know about a study in progress, which is the Clinical Immunization Safety Assessment, or CISA, project study of the safety of quadrivalent recombinant influenza vaccine, or RIV4, versus quadrivalent inactivated influenza vaccine, or IIV4, among pregnant women. This is a randomized observer and participant blinded clinical trial. The study population consists of pregnant women aged 18 years and older who are at gestational age less than or equal to 34 weeks at the time of vaccination. Participants are randomized 1-to-1 to receive RIV4, or Flublok quadrivalent, or IIV4, Flulaval quadrivalent. Maternal and infant safety outcomes are collected from enrollment through 90 days postpartum, and local and systemic reaction data are collected from vaccination day through day 8 after vaccination. Blood is collected at baseline and 28 days after vaccination for immunogenicity assessment. Participants are being enrolled from 3 sites during 2019-20 and 2020-2021 influenza seasons, with a total goal of 430 participants. To date, the study has enrolled and randomized 233 participants during the 2019-20 season. A safety review was held in which a panel of 3 medical experts who are not study investigators reviewed the interim safety data for serious adverse events. Each panel member concluded that there were no substantial safety concerns observed, and the current plan is to continue enrollment into the 2020-2021 influenza season. More information will be presented on the study at a later meeting. Before moving on and leaving the safety section, we'd like to acknowledge the Immunization Safety Office personnel, as well as FDA, VSD, and CISA staff who produced this work and also provided these slides, as well as a few additional safety slides, which we'll see in the next section. So finally, the last section, work group considerations and the proposed 2020-2021 recommendations. In the next few slides, I will outline the proposed changes to the influenza statement for the 2020-2021 season. The core recommendation is unchanged. Annual influenza vaccination is recommended for all persons aged 6 months and older who do not have contraindications. There are two primary updates to the recommendations. First, the U.S. influenza vaccine viral composition, which has been updated for 2020-21, and second, inclusion of two recently licensed vaccines, Fluzone high-dose quadrivalent and Fluad quadrivalent. First, with regard to vaccine composition, for 2020-21, there have been updates to the influenza A H1N1 PDM09, influenza AH3N2, and influenza B Victoria components. These are the components shown in red on the slide. The B Yamagata component is the same as the last season. Note that for this season, they have specified a different composition for egg-based versus non-egg-based vaccines, at least for the influenza A viruses. These are not actually distinctly different vaccine compositions. FDA has for several years now specified different reference strains for egg versus cell-based vaccines. It's just that it's being explicitly stated. You'll notice that generally the viruses are referred to as PDM09-like viruses, H3N2-like viruses, and in general for any particular target virus that is desired to target for the coming season, there are several possibilities for suitable viruses, and that is reflected here. Second primary update is that there are two new influenza vaccines that were licensed after the publication of the 2019-20 statement and which are expected to be available for the first time during 2020-2021. First, in November 2019, the FDA licensed Fluzone high-dose quadrivalent from Sanofi Pasteur for ages 65 years and older. Like the previous trivalent high-dose vaccine, this vaccine contains 60 micrograms of hemagglutinin per vaccine virus for a total of 240 micrograms in a 0.7 milliliter dose. The 0.7 milliliter dose volume is slightly higher than that for all other injectable influenza vaccines, including the previous trivalent version of Fluzone high-dose, which is 0.5 milliliters. This vaccine will replace the previous trivalent Fluzone high-dose for 2020-21. Pre-licensure data were presented to the ACIP in October 2019. Then in February 2020, the FDA licensed Fluad quadrivalent from Seqirus for persons aged 65 years and older. This vaccine contains MF59 adjuvant, similarly to the previously licensed trivalent version of Fluad. Pre-licensure data were presented to the ACIP in February 2020. Those are the principal changes. We have a number of other changes that are notable, which I'll discuss next. First, with regard to the contraindications and precautions table, or Table 2 in the guidance. The text of the header in that table, which previously read contraindications and conditions for use is not recommended, has been changed to read simply contraindications. The original header reflected the fact that for one of the vaccines, LAIV4, there are some labeled contraindications that are listed in the package insert and others which are not labeled contraindications but are situations in which ACIP recommends LAIV4 not be used. However, following discussion of this issue in the context of the adult and pediatric schedules at the October ACIP meeting and ensuing workgroup discussion, the workgroup consensus was that it is more clear to simply call these contraindications in the table. The text of the document provides more detail concerning which contraindications are labeled contraindications in the package insert and which are ACIP recommended contraindications. There's another change to the contraindications and precautions table, which involves the use of LAIV4 in specific populations, those with cochlear implants, active CSF leaks, and anatomic or functional asplenia. The text of the document for several seasons previously indicated in the section on vaccination of immunocompromised persons that vaccines other than LAIV4 should be used in these populations. The basis for this was the fact that LAIV4 is a live vaccine, the lack of data on the use of LAIV4 in these groups, and the availability of alternative vaccines. These conditions were not explicitly listed separately in the contraindications table, however. The workgroup recently revisited this issue. To help inform the workgroup discussion, the Immunization Safety Office conducted a targeted review in VAERS for LAIV-related reports in these populations: asplenia or sickle cell disease, and cerebrospinal fluid leak or cochlear implant. As a reminder, VAERS is the Vaccine Adverse Event Reporting System, a U.S. spontaneous reporting surveillance system which has been operating since 1990 and is co-managed by CDC and FDA. VAERS receives adverse event reports from manufacturers, medical providers, vaccine recipients, and the general public. This was a review of primary U.S. reports between July 1990 and March 16, 2020. Vaccines included were LAIV, whether monovalent, trivalent, or quadrivalent, with or without other vaccines. There were no age restrictions. Search methods used include MEDRA preferred terms and text string search. This search yielded 2 reports related to asplenia or sickle cell disease. For sickle cell disease, 1 non-serious report in a child, and for asplenia, splenectomy, 1 death report in an adult. There were 3 reports related to cochlear implant, all non-serious reports in children. There were no reports for CSF leaks. In addition, a literature search developed with a librarian using terms based on influenza vaccine and cochlear implant, cerebrospinal fluid leak, CSF leak, anatomic asplenia, functional asplenia, or sickle cell anemia was performed. This yielded 141 citations, but no data related to the use of LAIV in these populations. In workgroup discussion, it was noted that there are insufficient data reflecting use of LAIV4 in these populations, and there are also alternative influenza vaccines available. In the proposed document, these conditions have been added to the list of contraindications for LAIV4, specifically in the table. The next update concerns the use of influenza antivirals and LAIV4. The statement has for several years indicated that use of influenza antivirals from 48 hours before to 2 weeks after administration of LAIV4 may interfere with the effectiveness of vaccine, since LAIV4 contains live virus that must replicate in the nasopharynx. This time interval, the specific one noted, is also noted in the package insert for LAIV. However, the newer antivirals peramivir and baloxavir have longer half-lives than oseltamivir and zanamivir. Unfortunately, there are insufficient data that are available concerning the use of live attenuated influenza vaccine in the setting of influenza antiviral use. We don't know whether and to what extent interference with the vaccine might occur, but it seems biologically plausible that interference could occur. In discussion of these things with the workgroup, the following was proposed. Based on the half-lives of the antivirals and assuming a minimum of 5 half-lives after the last dose being needed for adequate washout of antiviral, language has been added indicating that it is prudent to assume interference might be possible if antivirals are administered within these intervals. For oseltamivir and zanamivir, 48 hours before to 2 weeks after LAIV, for peramivir, 5 days before to 2 weeks after LAIV, and for baloxavir, with the longest half-life, 17 days before to 2 weeks after LAIV4. The last change, it relates to vaccination of persons with egg allergy. Language concerning persons with a history of severe allergic reaction to egg, that is, having had any symptom other than hives after egg ingestion, has been updated to reflect the availability of 2 egg-free vaccines, the cell culture-based inactivated vaccine, or CCIIV4, and the recombinant influenza vaccine, or RIV4. For the last several seasons, for individuals with a history of severe reaction to egg, the language has specified that those individuals should be vaccinated in a medical setting under the supervision of a healthcare provider who's able to recognize and manage severe allergic reactions. However, for this season, that language has been updated to indicate that for these individuals, these conditions hold if a vaccine other than CCIIV4 or RIV4 is used. So in summary, principal changes are the 2020-2021 influenza vaccine composition and inclusion of the newly licensed Fluzone high-dose quadrivalent and Fluad quadrivalent as appropriate vaccines for those 65 and older. Other changes, Table 2 now says contraindications rather than contraindications and conditions for use for which use is not recommended. Asplenia, cochlear implant, and active CSF leak are included in the contraindications in Table 2. There's updated guidance concerning LAIV4 and influenza antivirals based on half-lives of various agents, and updated language concerning the vaccination of persons with egg allergy to reflect the availability of egg-free vaccines. And I believe that's my last slide. Thank you very much. I'd be happy to take any questions.
Thank you very much, Dr. Grosskopf, for that excellent summary of the excellent work done by the influenza working group. I'll open it up now to questions or comments from the members. I noted that Dr. Lee and Dr. Szilagyi both have their hands up. I'm not sure who got there first. Dr. Cohen?
Yes, Dr. Lee, and the next is Szilagyi.
Very good. Proceed, Dr. Lee.
Thanks very much. Dr. Grosskopf, thanks so much for your excellent presentation. So on slide 16, there are higher effectiveness estimates noted against H1N1 PDM09 in adults 50 and older. And so my question was really around, given the age difference that's noted, did you take a look at prior receipt of influenza vaccine as potential reason for those differences?
I couldn't completely understand the question towards the end. Could you repeat that? I'm sorry, Dr. Lee.
That's okay. Given the slight differences noted by age group, I was wondering if you had any information about prior receipt of influenza vaccine as a potential reason for those differences, given the younger age group probably has been more consistent in vaccine use than the older age group.
Okay, I think I got it. I think I got it that time, whether we have data on prior receipt and what that might possibly have in terms of effect. I don't have that information right now. In a number of previous seasons, the Flu-VE network has managed to put out analyses in looking at various seasons of prior vaccination history. I would anticipate that they might look at that in the future, but as of today, I don't have any information on that. But that's an important question.
Dr. Szilagyi?
Yes, Dr. Grosskopf. Thank you for an excellent presentation, as always, and for your thoughtful and very careful leadership on the flu work group. I had a question and then a couple of comments. Do we have any updated information about LAIV use? This is for the Flu-VE data. I suspect it was very low, but is anything updated?
Nothing as of yet. I mean, I think that there has not been a lot of use of LAIV within the network facilities for the last couple of seasons. I don't think that is changing this year, but we'll have to see more when the data are more finalized and the previous receipt history is also finalized. I am guessing that we probably won't have an estimate this season, but we'll know more later.
Okay, and just a couple quick comments. Since there was a difference in VE for influenza A versus B among children for both age groups, with confidence intervals just barely crossing 0 for influenza A, it may be helpful in future slides to show the VE for the combination for all influenza. Looking at the point estimates and the confidence intervals, I'm pretty sure there's going to be a significant VE for children for both age groups if we combine them. And then the second comment kind of related to that, and this is related to the overall VE. I think it's always worth emphasizing that a VE of almost 40% means that we are eliminating or reducing 40% of outpatient influenza medically attended visits, which is millions of visits in the United States. And that's, although it's lower than what we would hope, it's a very significant reduction in morbidity due to influenza vaccine. Thank you.
Agreed, thank you. And I will also take the comment about the depiction of the VE data back to the VE group. Thank you very much.
Thank you very much, Dr. Szilagyi. Dr. Bernstein?
Wonderful presentation as always. I just wanted to ask whether what plans might be in place for looking at influenza and SARS-CoV-2 in the Southern Hemisphere. What are people looking at and how might that help us in the Northern Hemisphere?
I regret to say I'm actually not aware of what the specific plans are at this point, although that is an excellent question. We can try to find out more about that and get that information to you later.
Thank you.
Dr. Cohn, is there anybody from the voting members that I'm missing for comment?
Lynn Bada.
All right, yes, Ms. Bada.
Yeah, I was interested in some of the patterns this spring as the H1N1 pan09 was rising, and then it had such a precipitous fall. Was that fall related to people stopping testing because they were testing for COVID, or was that a true decline that fast?
Difficult to say. It could be a combination of things. By the time the flu activity began to fall, that would not have been an atypical period of time necessarily for influenza activity to fall. The peak did seem to be running from about late December into February, so it wouldn't be uncommon to see that kind of a drop, although your point is taken about the fact that it does look somewhat precipitous, and it's difficult to say what the testing patterns were during that period of time.
Dr. Romero, those are the questions from the ACIP members.
Thank you very much. Do we have any questions from the liaison representatives? I see that Dr. Sanchez raised his hand. Let me ask him to comment or question, and then I'll go on to Dr. Kimberlin. Please, Dr. Sanchez.
Hi, sorry. I was trying to find my hand. So I understand the reason for the sickle cell and for the with the LAIV with sickle cell and asplenia and also cochlear implant and CSF leak as being put into the contraindication. But I think some comment, at least with the CSF leak and the cochlear implants, should be put into that data are just insufficient. Because when people see that, as providers see that, and it's an absolute it's a contraindication, there's heightened concern if given inadvertently or if that's if that's the only way you're going to vaccinate a child. But I just think that some comment, maybe just a footnote, that data are just on safety are just insufficient.
Thank you for that comment. It's not really directly noted in the table. It is noted in the text. We could perhaps consider adding a footnote to the table.
Yeah.
Thank you very much. Dr. Kimberlin, please.
My comment is exactly what Dr. Sanchez just made mention of. 2 reports of asplenia or sickle cell disease in bears, 3 reports of CSF leaks or cochlear implants in bears. That hardly seems enough to me personally to warrant a contraindication. And while that I may not win on that kind of an argument or discussion point, at the very least, making mention of the weakness or perhaps even lack of data would be warranted, and that this recommendation is being made perhaps out of an abundance of caution or something like that.
Thank you very much. Yeah, I understand what you're saying, and that is more or less the 10 tenor of the recommendation. There aren't much data. There is not much in VAERS, as you saw, and the recommendation is largely based on the fact that we don't know, but we do have alternative vaccines, and there are some biologically plausible things to be concerned about. The other thing that we have to consider is the whole issue of the table of contraindications and trying to be as simple and direct and easy to interpret as possible in that table, which was a point that was raised back in October. And this was really the best kind of compromise that we could come up with. But point taken, thank you.
Thank you very much. Dr. Hunter.
Right, I just wanted to follow up on Lynn Bata's comment about the sudden decline in influenza. I'm just wondering, at the end of the season, was that coincident with the social distancing, physical distancing, implementation of that as COVID was getting started, or did it happen before or significantly after that time period?
That could well have been. The data is in that network is national, and of course things probably were different in different parts of the country with regard to activity, but that could be plausible, yes.
I guess the reason I ask is that it'd be nice to know whether or not approaching seasonal influenza with targeted physical distancing for a limited amount of time every season might be something to consider as something to include in influenza recommendations in the future.
Thank you for that comment.
Dr. Atmar, please.
Yeah, thank you. I wanted to also comment on Ms. Bata's question. That slide also had a line that showed the percent positive. And so the percent positive for influenza positivity dropped precipitously. At the same time, the number of isolates decreased. So I think it was real. Anecdotally, one of my colleagues here in Houston, who does a lot of viral diagnostics and surveillance, noted a precipitous change in the identification of all respiratory viruses as physical distancing, social distancing was rolled out in our community. So I think that this was probably not unique to influenza and may well, at least in the Houston area, have been associated with the social distancing measures that were taken to try and limit the spread of the SARS coronavirus too. Thank you.
Thank you, Dr. Atmar.
Thank you. Dr. Quashsan?
Yes, thank you for the presentation. I was wondering, given the anticipated next wave of COVID-19 in the fall, if the ACIP Influenza Working Group was anticipating any changes in your vaccination administration program.
This is Dr. Cohn. We actually have a talk that's going to update you all on our influenza program implementation plans for the fall during the COVID session this afternoon.
Thank you.
Any other questions? Any questions from the ex officios or comments? Okay, apparently none.
Jose, can you hear me? Oh, sorry. This is Sean O'Leary. I'm not able to raise my hand.
Sure, Sean. Dr. O'Leary, go forward.
Yeah, Pediatric Infectious Disease Society. So regarding the egg allergy language, I've said this before, but why do we continue to call out egg allergy? So question number one, when there's accumulating evidence that severely egg allergic individuals are not at higher risk of anaphylaxis than the general population, I see that as a barrier to influenza vaccination if PCPs feel like they can't do it in their office and have to send those children to an allergist. And then the second point is that the language is essentially identical to the language in the general recommendations on immunization. All immunizing providers are supposed to be able to handle anaphylactic reactions. And so by calling out these non cell-based vaccines is creating an exception for those vaccines where there are no, to my knowledge, exceptions for any other vaccines. All vaccines are supposed to be administered in that setting.
Thank you for that comment. This is a topic that's been discussed probably during most years of the last 3 or 4 at least, and we are aware that there is increasing data, and actually a lot of data already indicating that probably severe allergic reactions are unlikely. However, with the current incarnation of the language before this recent change to mention the egg-free vaccine specifically, arose out of an abundance of caution and out of some concern discussed at the ACIP meeting where that language was developed and refined, that there may be settings, particularly as more and more people are getting vaccinated outside of their medical home, where it's possible that adequate equipment might not be available or adequate personnel might not be available. The recommendations is written, the work group's thinking is more or less that it's already reasonably permissive as far as location of where to vaccinate. With regard to having exceptionalism for CCIIV4 and RIV4, it just seemed to make sense at this point that since those vaccines are egg-free, that should be noted. This is something that we'll be continuing to revisit, probably with a review at some point in the near future.
Okay, yeah, it doesn't seem to me that having an exception for those 2 vaccines, there's no evidence that they're any less likely to cause an allergic reaction than any other vaccine, and so it's not consistent with the general recommendation.
Yeah, and we continue also to follow that in VAERS. Actually, the initial season after the recommendations changed to be more permissive, which I believe was for the 2011-2012 season, when we began looking at that at the annual safety update in VAERS, there have been some rare isolated incidents of people with a history of egg allergy who have had reactions. So that's another reason that stayed. Definitely not a common occurrence. The other thing I just wanted to mention, because I neglected to mention it in that section, CCIIV4 and RIV4 are not going to be for everybody. As we know, egg allergy tends to be more of an issue in the pediatric population, and RIV4 is actually only licensed for 18 and up, and CCIIV4 for 4 years and up, so it's not going to be for everybody. Just meant to add that. Thank you.
Thank you very much for that comment. Any other questions or comments? I'll give a moment for somebody to suppose they need to.
We have Dr. Freihofer and then Dr. Bernstein.
Thank you very much. Dr. Freihofer.
Sandra Freihofer, American Medical Association, speaking as a general internist in practice who sees patients and will be conducting flu clinics. I greatly appreciate ACIP being very cautious in these recommendations, especially this year. I think with COVID and trying to get patients immunized, we're going to be getting flu vaccines and perhaps some non-traditional locations. And I really appreciate erring on the side of caution to make those flu vaccination clinics as safe as possible. And this has been a great discussion, but I really think that the way that the wording is now is very helpful for clinicians and will help keep everybody safe.
Thank you very much. Dr. Bernstein.
Yes, thank you. I just had a question if somebody from Sanofi is in the audience. With the fact that 0.25 milliliter pre-filled syringes of Fluzone will no longer be available for infants 6 months through 35 months, only the multi-dose vial, will Sanofi note or make it clear that the multi-dose vial should only be used for 10 0.25 doses and not more?
Thank you. Dr. Rizzo, would you please answer that question if you're in the audience?
Sure, I'm here. Can you hear me?
Yes.
Yes, sir.
Okay. I will double check on that. I believe that both doses are approved. The question was that a maximum number from a vial?
Yes, from a multi-dose vial, since the pre-filled 0.25 ml product it will not be available this coming flu season.
Okay, I honestly don't know the answer to that, but I believe that the 0.25 is still an acceptable dose, but along with the 0.5.
The 0.25 is still an acceptable dose, but I was wondering how many doses. I don't believe they should be taking out more than 10 doses from a multi-dose vial.
Dr. Bernstein, could we follow up with you on that answer later in the day?
Sure, absolutely.
Great. Thanks, Dr. Rizzo.
Yes, I'll look into it.
Dr. Lee?
Thank you all. Dr. Lee?
Thank you. I just wanted to, was reflecting on what Dr. Sanchez and Kimberlin were saying about the wording, and I actually feel like it would be helpful for us to clarify how ACIP is defining contraindication. Specifically, I do feel like if we didn't have any other vaccines available, that the benefits might outweigh the risks of vaccination with LAIB for those who are asplenic or who might have CSF leaks, given we don't have any additional data to suggest harm. But another way to think about it is more like a precaution, which is not our typical language, or a preferential recommendation. And I think that would reflect the consensus of the group without confusing people about what the intent of that recommendation is. Thank you.
I don't see any other persons wishing to make a comment or question. Dr. Cohn, am I correct?
You are correct. We're going to pull up the language for someone to consider making a motion for influenza recommendations.
Very good.
This is Beth Bell. I'll make the motion.
Thank you. Do I have a second, please?
Dr. Atmar?
Second?
I second the motion.
Thank you very much. So we have a motion and a second. Are there any other comments or questions?
I just want to read the motion that was made for the record. The motion that's been made and seconded is to accept the changes to the ACIP influenza statement for the 2021 season.
Thank you. All right. No other comments or questions? Very good. So I want to thank the presenters. What we're going to do is now take a break. And so we will return at 25 minutes after the hour. We have approximately 9 minutes, if I am correct. Dr. Cohn, anything to add?
No, thank you very much.